Hello, everyone. Thank you for joining us today. My name is Jenny, and I'm a part of education team at Medit. Nice to meet everyone. And today we have a new carer here. Hello, doctor.
Hello, Jenny. How are you?
I'm so good.
Um, Thank you for this invitation and thank you for this very nice meeting. And I hope it will be a fruitful webinar full of knowledge for benefits for all of us. Thank you.
Thank you. So I forgot to introduce his name. So his name is Mohamed El Ahsry, right?
Yeah,
Okay, it's such a pleasure to have you here.
thank you. Thank you very much. It's my pleasure.
Okay, so before getting started, I would like to briefly introduce about Dr. Mohamed.
Okay, thank you. Go ahead.
Okay, so this is a profile page of Dr. Mohamed Al Ahsry. So he graduated from Alexandria University, where he earned a master's degree and a doctor of philosophy in prosthodontics. And during this time, he worked as an instructor of fixed prosthodontics at the same university, and he is currently an assistant lecturer and has been a private practice owner in Alet Microscope Dental Clinic, which is in Egypt, from 2013 and has been doing digital dentistry for over 7 years.
Yeah.
So is there anything you would like to add or correct?
No, this is enough for now. I'm also a lecturer in many events and conferences, national and international. Uh, this is all. This is what we want to say, because being a digital and microscopic specialist actually is highlight of my
No.
practice because
Yes.
I like to be a digital and microscopic dentistry, and I like this practice very much. This is my main concern, and this is my main career in the last few years.
Oh, okay. Thank you for adding more information about you.
Thank you, Jenny.
So you are in Egypt, right?
Yeah, I am in Egypt. I am in
Mhm.
Alexandria University.
It's so far away from Korea.
Yeah, so for around 10 hours.
10 hours. Oh.
Yeah, 10 hours.
So you might have been asked like this question 100 times. So have you ever been to pyramids?
For me, yes, a lot of times. I should ask you. I should ask you, have you ever been in pyramids? I
I
should
want,
invite you to
I
visit
really want
pyramids.
to.
We should invite you to visit pyramids soon.
Please.
Yeah, sure. We'll invite you one day.
Wow. Thank you.
Thank you
Okay.
very much.
Uh, okay, let's go back to our webinar topic.
Okay, let's start.
Okay, so we are back to the webinar topic. So let's talk about it. So it's about ideal gingival retraction. So can you tell us some contents that you're gonna discuss with us today?
Sure. Optimizing digital scan with ideal gingival retraction is one of the hugely overlooked topic in the practice of digital prosthodontics, because I am receiving lots of questions regarding what is the ideal gingival retraction method for digital scan. And I'm receiving also lots of problems regarding inaccurate marginal adaptation after digital scans, and the problem is clear. It's about gingival retraction. So I'm going to discuss the ideal and the how we can control the quality of the gingival retraction for a good digital scan with a lot of methods that can optimize our digital scan. I will discuss a lot of tips and tricks regarding digital gingival retraction to achieve ideal marginal recording, and I hope it will be fruitful and full of knowledge.
Oh, you think that gingival retraction is like a key success to go to the perfect scanning, right?
Definitely, because if you are doing a very nice prep and you didn't do a good retraction, your crown will be short, under contoured, open margin, which will affect the quality of your restoration. So even with a good prep, without a good retraction, the restoration will have failure. So it's very important to do ideal gingival retraction, especially with digital scans.
Everyone will be so excited to attend this lecture.
I hope it will meet the expectation.
Yeah. Okay. So shall we begin, doctor?
So thank you, Jenny, for this very nice introduction for me. And let me introduce myself once more. I am Mohamed El Ahsry. I am assistant lecturer of fixed prosthodontics at Alexandria University. And today's topic is optimization of digital scans with ideal gingival retraction, because gingival retraction is one of the hugely underrated topic in the practice of digital prosthodontics, because sometimes we have a very nice preps and a very good scans, but the problem is with not enough gingival retraction, leading to a lot of problem regarding to incomplete marginal integrity and incomplete seating of the final restoration. So today I'm going to discuss in details gingival retraction and gingival retraction methods for a good and ideal digital scans. And because usually in prosthodontics and as a prosthodontist, our role is to achieve and to restore the missing teeth, to restore also the aesthetics, to restore the function, and to achieve ideal occlusion. And because usually in digital prosthodontics, our target is to achieve precision in a predictable way. So to achieve this precision, we have to gain the ideal precision in marginal adaptation and in aesthetic outcome and in the ideal fit of the restoration and finally in the occlusion. And all of these items are related mainly to the impression procedures. Either you are doing a traditional impression with light body wash impression, which is proving according to evidence and according to literature that is very accurate in recording the margins and the finest detail of the sulcus. Or you are using digital impression, which is also proven by literature to be a very nice in recording the subgingival part of the tooth and to record the finish line and the margins. But you have to know the main difference between the physical impression and the digital impression. And you have to know the 5 main concerns to achieve the required precision in digital impression. And these concerns are the main difference between the digital and the conventional impression. And these concerns are, the first one is the reduction criteria. Should we modify our reduction for a better gingival scan? The second one, which is my today's topic, which is the tissue management, how we can modify, how we can adjust the tissue management for ideal gingival retraction. The third one is the ideal data, how we can record the ideal data for a good and precise restoration. And then the models, are we still in need for models in the practice of digital prosthodontics or not, which is also very important, because usually we are in need for models in implant prosthetics, for example. Sometimes we are in need for models in a full mouth cases. And finally, the occlusion. What is the difference between the conventional protocol and the digital protocol regarding the occlusion? Are we still in need for more physical tools like semi-adjustable articulator or Facebook transfer? Should we make a physical mounting and adjusting the angles? The answer is there is a huge difference between the conventional and the digital workflow, and all of these items will be discussed later on in another lecture. So for today's topic, which is the tissue management, what is the difference and how we can achieve a good tissue management for a good and ideal digital scan? Because nowadays we are doing a minimally invasive brips with a very narrow margins around 0.3 to 0.5 millimeters. So it's very crucial to retract the gingiva away from this very thin margin to be able to fabricate the restoration with a good and ideal marginal integrity. So to achieve this marginal integrity and this very nice marginal adaptation between the final restoration and your finish line, retraction should be achieved with a very accurate way. Usually after we finish the reduction, the gingiva collapse again over the margins and with a lot of bleeding. This bleeding will interfere with the scanning and the ideal capturing of the final details of the finish line. And because we cannot penetrate the bleeding like the light body impression, we cannot retract the gingiva more with the scanner like light body impression. So it's very important to retract the gingiva and very crucial to stop bleeding. So in light body impression, as I discussed before, the light body can be injected into the sulcus, retracted the gingiva slightly away from the finish line, even with slight bleeding. But sometimes with heavy bleeding, we cannot record the ideal detail of the margins because the materials is hydrophobic and cannot penetrate the heavy bleeding and cannot record the finest detail of the sulcus. So we can have a lot of problems regarding air bubbles in the finish line and incomplete recording of the details. And then after boring, we can have incomplete photo or incomplete recording of the margin and a lot of air bubbles and a lot of voids in the axial wall of the reduction. And this might lead to marginal inaccuracy and incomplete seating of the final restoration. And the same for digital scan. For example, for this case, we have a tissue on top of the finish line, so we cannot penetrate this tissue to record the ideal width of the finish line. Also, we have a bleeding here, so the camera or the scanner cannot penetrate this bleeding to record the margins. So it's crucial to retract the gingiva to stop the bleeding, to be able to record the final widths and the ideal widths of the finish line and the sulcus. So usually our rule for tissue management is to achieve a good horizontal gingival displacement, an ideal vertical gingival displacement, and also to achieve a good hemostasis. So why we need horizontal gingival displacement for digital scans? We have to retract the gingiva in a lateral way, in a horizontal way to expose the full width of the finish line, to avoid a lot of complication regarding ideal capturing of the margins with a lot of problem regarding to the final restoration. The first one is under contoured margin because the gingiva is not completely retracted. The second one, which is the short margin due to incomplete and not ideal retraction of the gingiva away from the margins, leading to a very short margin like in this situation. And another crucial problem that when your technician is trying to modify the gingiva with free forming, we can lead to an open margin with a lot of problem regarding to incomplete seating of the restoration and a lot of recurrent decays with a lot of problem regarding to failure of this restoration. Another important factor is to achieve a good vertical gingival displacement. So we need more vertical displacement of the soft tissue to expose unprepared to surface below the finish line to be able to design for an ideal emergence profile. Because emergence profile is critical for a good gingival healing. Because sometimes if we are not retracting the gingiva in a vertical way, the restoration will be slightly over contoured, and if we have a very thin biotype, this over contouring can lead to persistent inflammation and permanent soft tissue recession and vertical height loss. So for this situation, for example, we can achieve a good vertical and a good horizontal displacement, which is good for achieving a final good scan for a good restoration with a very nice marginal integrity. So for example, for this case, if we took a cross-section buccolingually, in the buccal line, in the buccal section, we can see that we can differentiate between the margin and the finish line because we have a good horizontal displacement and a good vertical displacement. But for the palatal surface, we cannot differentiate at all between the margin and the bleeding and the gingiva. So control the bleeding and achieve hemostasis is very, very important also. As I discussed before, the light cannot penetrate the bleeding, so it's important to stop the bleeding before a scan. Here's a scan with the bleeding around the margin, so it's very difficult here to record the margin and very difficult to detect and to determine the final margin of the restoration. So our rule is to select the ideal tissue management protocol to achieve vertical horizontal displacement and to achieve ideal hemostasis without any heavy pressure in soft tissue and without any trauma to the soft tissue that might lead to further soft tissue recession. So usually the tissue management protocol are three. The first one are the chemomechanical method, which is the most famous method, like retraction cord. The second one is a chemical method like retraction based, and finally the surgical method like laser and diatherm or electrosurgery. Retraction cord usually as a chemomechanical method is the most famous method and the most common material used for many of the dentists. Retraction cord usually have many classification. According to the size, we have 000, we have 00, we have 0 and 1, 2 and 3 according to the size. And sometimes we have impregnated cord and non-impregnated cord. And we have a knitted design, we have twisted design, and we have a braided design. So it's better and more preferable to use knitted design because after placing the knitted cord in the sulcus, it can absorb some of the crevicular fluid and the bleeding with more expansion, with further and more soft tissue retraction horizontally and vertically. So the knitted design is the most commonly used retraction cord for its benefits. So usually after replacing the cord here, it can expand and moving the gingiva and retracting the gingiva in a vertical and horizontal direction to expose the margins. How we can apply retraction cord? First of all, I'm starting from the deepest sulcus to then moving to the shallowest sulcus interproximally or buccally and lingually according to the probing depth. And usually I like to place the cord with serrated retraction cord becker, or I can use rounded end retraction cord becker. So we should apply the pressure in a very gentle way to avoid soft tissue recession or to avoid heavy trauma on the soft tissue. So what is the ideal size of the retraction cord and how we can determine the ideal size of the retraction cord? The answer is depending on the sulcus width and the sulcus depth. According to the sulcus depth and width, we can determine to use which size of the cord to be used in every situation. For example, for this case, we have a very shallow sulcus. I have a very thin biotype, so I am placing cord 000. And in case of a larger sulcus, of a deeper sulcus, I can place 00, and sometimes I can place size 0. And if the sulcus is deep enough, I can place size 1 to retract the gingiva more efficiently in cases of overlays and even in crowns. So in this case, I have a thick biotype that can accommodate for the pressure of this large cord. Again, how to achieve the ideal hemostasis with the retraction cord? Retraction cord can achieve a good vertical and good horizontal displacement, but how we can achieve hemostasis? Usually, if the retraction cord is impregnated or non-impregnated, I like to soak the retraction cord in hemostatic solution. And usually, my preferred solution is Viscostat Clear, which is a clear gel that can be used for hemostasis. It contains 25% aluminum chloride. So I am soaking the cord in this gel for around 5 minutes. Then after removal of the cord from the gel, I will make drying for this gel to avoid any trauma from excessive chemicals around the gingiva. And then I am placing the cord into the sulcus and it will achieve a very nice and very good hemostasis. Aluminum chloride is also very effective in hemostasis and it will not do any discoloration or any pigmentation to the soft tissue or to the tooth, unlike the ferric sulfate, because ferric sulfate can cause a lot of discoloration and a lot of pigmentation in the gingiva and the dentine surfaces. So for me, it's better to use aluminum chloride gel or aluminum chloride solution in posterior teeth and even in anterior teeth to avoid any discoloration of the ferric sulfate. And then I'm going to detect the margins using manual margin detection, or thanks to the very nice tool of Medit margin, which is automatic margin detection. If your margins are very clear and gingiva are retracted enough, you can select or you can detect your margin in 1 second with automatic margin detection. And this healing of the gingiva will not be achieved without ideal final or ideal sealed final restoration, because this gingiva will heal around the sealed margins. If your margins are not sealed enough, if you have short margin over contoured or under contoured margins, your gingiva might be affected. And even in the anterior teeth, this seamless margin adaptation and this seamless adaptation of the gingiva to the contour of the final restoration without any inflammation cannot be achieved without ideal retraction, without heavy pressure that might cause recession on the long-term follow-up. A very important point is to scan with the retraction cord in place or without the retraction cord. And to answer this question, we have to know the three main criteria of the tissue that is going to be retracted. The first one, if we have a thick biotype or thin biotype, if we have a deep sulcus or a very shallow sulcus, if we have a healthy tissue with controlled bleeding or even without any bleeding at all, or unhealthy tissue with profound bleeding. Because if you have a very thick biotype with deep sulcus, we can remove the retraction cord just before the scan, and now we have around 30 seconds. The gingiva are completely retracted away from the margins to be able to capture and record your margins. But if the gingiva is not thick enough, and the sulcus is not very deep, and the tissue have a lot of bleeding, and we cannot control the bleeding without the retraction cord in place, it's better to scan with the retraction cord as long as the retraction cord is not covering the margins at all. So you have to make sure that the retraction cord is completely below your margins and not covering the finish lines at all. But sometimes we have a lot of problem regarding open margins and faulty margins even after good retraction and even after controlling the bleeding. For example, for this case, after I placed the first cord, the gingiva collapsed again over the finish line, and we cannot record the margin in this case. Like here in this scan, we can see that the margins are completely covered by the tissue in the buccal surface. So if we scan the margin in this way, we might have an open margins or sometimes short margins. So what to do in this situation, although we are doing a good retraction and the retraction cord already in place? In this situation, I prefer to place a double cord, a second large cord without heavy pressure on the soft tissue, just to retract the gingiva away from the finish line, and then after 5 minutes I can remove this cord, and then I can take a scan. So the gingiva is completely away from the margins and the finish line can be ideally recorded. So my protocol usually is placing first cord either from size 00 or 000 for a slight vertical and horizontal displacement and for a kind of hemostasis, and then placing a second cord without heavy pressure for more horizontal and vertical displacement and to control the bleeding and to stop any bleeding around the finish lines. And here we can see the difference between the two scans and the importance of the second cord for retracting of the gingiva completely away from the finish lines to achieve the ideal marginal adaptation of your final restorations. So my protocol usually in many cases and in different case scenarios is to place the first cord, then placing the second cord, larger cord,
for more vertical and horizontal displacement, the removal of the second cord, and finally I can take the scan. In another case, with the same protocol, single cord, double cord, then single cord. And also for the anterior teeth, it's very effective to retract the tissue away from the finish line. But you have to avoid any heavy pressure during the placing of the second cord to decrease the trauma to the soft tissue to avoid recession after removal of this cord. And finally, I can take the scan. And those are the final restoration immediately postoperative with a good healing of the soft tissue around the margins. So usually in deep rips and in thin biotype, I like to place the double cord technique also to control the bleeding. And because sometimes in cases like this, when we have a very deep rips and also when we have a lot of bleeding, it's very difficult to control the bleeding with single cord. So is it better to take a physical impression rather than a digital impression? Usually my protocol, I am not using physical impression anymore. I am using digital impressions. So I am placing the first cord even with this bleeding and collapsing of the gingiva. So I can place a second cord on top of this cord for more retraction. And this cord also should be impregnated with aluminum chloride to control the bleeding, and then I'm removing this cord after 5 minutes to record the margins of my restorations. And also in vertebrates, in very deep rips, I can use the same technique, placing the single cord, then another double cord, then after 5 minutes, I can remove the second cord and I can take the final scan with a good margin recording. So our rule to select the ideal technique to achieve the nice healing of the soft tissue around the margins and also to record the margin in ideal way without any traumatic pressure to the soft tissue. And then moving to the next challenge, which is full mouth reduction and full mouth brips, and how we can scan for full mouth reductions. The problem in full mouth brips is that when we are placing retraction cord, I mean the large cord, for more than 5 minutes, we might have recession. So it will affect the quality of the final restoration, and also we might have unaesthetic restoration due to the exposure of the margin or exposure of the finish line. So to record a case like this with around 24 brips, we have to retract the gingiva in a atraumatic way. So usually my protocol is to place the cord quadrant by quadrant. So I'm placing the first cord for one quadrant, then placing the second cord also for one quadrant, and then I am scanning one quadrant and moving to the other one with the same sequence to decrease the trauma to the soft tissue and also to avoid any recession for the final restoration. And this is always my protocol for many cases in full mouth preps. BTFE cord is also another material for a good mechanical retraction. BTFE cord or Teflon membrane is effective for complete exposure of the finish line. And because we have the white color of the Teflon, we can differentiate and we can have a good contrast between this white color and the discolored margins of our brips. But we have to know some essentials for BTFE to be able to use the BTFE in the ideal situation. BTFE is a hydrophobic material, so whenever I am in need for hemostasis, I cannot use BTFE cord. So in deep sulcus, in healthy tissue, and in thick biotype, I can use BTFE membrane or BTFE cord. Because if we have a bleeding like this, we cannot differentiate and we lost the very important criteria of the white Teflon, so it became discolored now, so the contrast between the Teflon and the margin cannot be achieved. Also in thick biotype, we can place the retraction cord because it need a kind of pressure that might be very stressful and very traumatic to the Senpai type kind of gingiva. So these cases with thick biotype, I can place Teflon even around implant in overlays, in inlays and overlays, and also in preps around the implant. But the most important factor also is to have a deep discolored margins, because when we have discolored margin, we can use the benefit of the contrast of the white Teflon. But if our margins are completely in enamel, so we cannot differentiate between the white color of the enamel and the white color of Teflon. So when we have a shallow margins, we should have a deep sulcus, because shallow margins are usually in enamel, and deep sulcus would allow the Teflon to be placed deeply away from the enamel margins, so we can differentiate between the enamel and the Teflon. So Teflon is a very nice material for mechanical gingival retraction as long as we know its limitation. So placing the Teflon or the BTFE cord in a thick type is ideal to avoid any excessive trauma with Teflon placement. Also, placing the Teflon in a deep sulcus is also good for a good contrast between the white color of the Teflon and the enamel margins. Also, placing the Teflon in cases which we are not in need for hemostasis is good, because Teflon is hydrophobic material and cannot be impregnated with hemostatic solutions. And now moving to another situation in which we have a very thin biotype gingival tissue. In this situation, placing a single cord might not be enough for achieving good retraction, and also soft tissue might collapse over the margin and over the retraction cord. And even using larger cord or double cord technique might cause a heavy pressure and trauma to the soft tissue with subsequent gingival height loss and permanent recession. So in mandibular anterior zone, in mandibular premolar zone, and also for the maxillary canine zone, gingival tissue is very thin, especially from the buccal side. So placing a single cord might not be sufficient to make ideal retraction and also for hemostasis. So in these situations, we need another material that can cause more vertical and horizontal displacement for the tissue and also hemostasis. So I'm using retraction paste, which contain aluminum chloride. This paste is efficient for hemostasis because of the effect of the aluminum chloride. But this material is not efficient for achieving good vertical and horizontal displacement, because the minor displacement caused by this material is only caused by the viscosity of the material when placing and when injecting into the sulcus. So we need another material to achieve ideal retraction. So we are placing the single cord, then placing this retraction based on top of the cord to achieve the ideal retraction and the ideal hemostasis. So this retraction paste is mainly used for hemostasis due to the effect of aluminum chloride. Also, this material can cause little pressure, so it will not cause any trauma to the soft tissue, especially the very thin biotype gingival tissues. Here is after removal of the cord and the paste, and this is the final scan with completely retracted soft tissue. Another situation in which we have all the crowns and we have a very thin and inflamed tissue, but in this situation we have to take an immediately post-operative scan after buildup to be able to fabricate a good temporary crowns. As you see from these photos, that the retraction cord is covering the finish line, so the margin will be deficient or short. So in this case, we have to place another material to retract the gingiva without causing more pressure on the soft tissue. And my favorite material here is X-Bacil. X-Bacil is also a retraction based, but different from the previous one, because this paste can expand after exposure to crevicular fluid, causing more retraction, more vertical and horizontal displacement. And also with placing of these combry caps, which is cotter rolls or customized cotter rolls according to the different teeth size and empty from inside. After placing these cotter rolls or this combry cap above the expressile, it can cause more pressure and also to make the expansion of the expressile in a lateral and apical direction, so exposing and retracting more of the gingival tissue. These expressile contain aluminum chloride also for hemostasis and kaolin, because kaolin can go hygroscopic expansion leading to more pressure and more retraction of the gingival tissue in lateral and apical direction. So in cases in which I cannot place retraction cord first, or I need a kind of retraction together with hemostasis, I like the expressile on top with combry cap to achieve the ideal retraction and the ideal displacement of the gingiva. So when we are injecting the retraction paste into the sulcus, the pressure caused by its viscosity can cause a slight vertical and horizontal displacement. Also, the hemostatic agent aluminum chloride can cause hemostasis for the bleeding. The kaolin, when it gets in contact with the bleeding and clavicular fluids, can undergo hygroscopic expansion for vertical and horizontal displacement of the tissue. And then after placing the combry cap, this combry cap and this cotter roll can force the expansion to be in a vertical and lateral direction to expose the margin and to retract the gingiva more. So this material is very nice for cases with a very thin body type, because the pressure of injection and also the pressure of combry cap is minimal, and it will not cause any permanent soft tissue recession or gingival height loss with a long-term follow-up. So as you see in this scan, the margins are completely retracted and the tissue is away from the margins, so we can record the finish line and we can fabricate a temporary restoration with a very nice marginal integrity. Another material option, which is magic foam. Magic foam is an expanding polyvinyl siloxane addition silicone. This material can be injected into the sulcus and can undergo expansion that can cause vertical and horizontal displacement also. And then after placing the combry cap, this paste can undergo more expansion in a vertical and horizontal way. But the disadvantage of this material is that it does not contain any hemostatic agents. So in cases that we need hemostasis, magic foam might not be efficient, although the expansion of this material can cause a slight hemostasis by the pressure. But in this situation, I like to place the retraction cord first to stop the bleeding, then removing the cord or injecting of this material on top of the cord for more retraction of the soft tissue. Also, this material is very atraumatic material for retraction of the soft tissue and for exposure of the margin. For this case, I was placing retraction cord first, size 00 for hemostasis, then I placed magic foam on top of the retraction cord with combry cap to achieve the desired retraction and exposure of the margins. So it's very important to customize your retraction protocol according to the gingival tissue and according to the depth of your reduction. So no single technique is most preferable for me. I can use every technique, I can customize each technique according to the desire for retraction and according to the health of the soft tissue and even the thickness of the soft tissue and the need for hemostasis. The final method for retraction, which is the surgical method. Usually I can use retraction cord for retraction, and also I can use laser for more hemostasis and more retraction in cases of thick bitype gingiva. In these cases, epithelial lining can be removed from the sulcus to expose the margin and retract the tissue. Laser also are beneficial for decreasing the bacterial load into the sulcus during the healing, unlike the electrosurgery or diathermy. because diatherm can cause heavy pressure and also can cause necrosis and severe burn of the soft tissue and also the bone if not properly used. So sometimes I can make some modification of my retraction protocol and even customization for my protocol. In this case, if I have bleeding for these crowns, I can place retraction cord, but retraction cord was not enough, so I can place retraction paste on top of the cord and then washing the paste. Now I have retracted tissue and I can do the final scan. Sometimes with BTFE retraction in a thick body type, the retraction is not sufficient, and replacing a double cord technique with Teflon will be traumatic to the gingiva and will not stop bleeding also, because as we discussed before, BTFE cannot achieve hemostasis. So in these cases in which BTFE is not enough for retraction, so the subgingival part is not clear enough to achieve good emergence profile. In this case, I prefer to place Teflon as a first cord and then placing retraction cord as a second cord to control the bleeding and to make more vertical and horizontal displacement. So in this situation, the tissue is not retracted properly and the margins is not fully exposed. So I am placing the second cord for 5 minutes. Now the margins are exposed and I can do my scan. So here my protocol is single BTFE cord, then double cord, then removing of this cord, then finally I can take the scan. Here you can see the margin is completely exposed and gingiva are away from the margins. Now we have fully exposed finish line, so we can fabricate our final restoration with ideal marginal seal. Another case with the same protocol, placing Teflon, then placing retraction cord to expose the margins. And here also another protocol, another case with the same protocol is placing retraction cord on top of the Teflon and then fabricating of the final restoration with a very nicely exposed finish line and very nice retracted tissue. Sometimes in a single case, I can do many retraction protocol. For example, for this canine, I am placing retraction cord, but for the other canine in the lateral, I can place BTFE membrane according to the need for retraction and according to the type of reduction that I have made. So both of the retraction method can achieve the ideal retraction for me to expose the margin, and this is the follow-up after fabrication of the final restoration. Here you can see the gingival health and the adaptation of the gingiva around the margins. So again, I have to remind you that we are doing retraction for exposure of the finish line to be able to manually or automatically detect our margin to send it to the lab to fabricate restoration with ideal seal, to avoid any gaps or micro gaps in the final restoration, so we can guarantee the ideal seal and the ideal fit of the final restoration. So we are not in need for these models anymore. We are not in need for removable dies fabricated of stone, because in Medit app software, in Medit model builder, we can do our removable dies, and I like this application because I can control everything regarding the removable die. So after printing these dies, I can adjust the final restoration if needed. I can make smoothing, I can make finishing and polishing of the margins if I'm in need for that in different cases. So my take-home message from this webinar or from this lecture is to know that retraction is mandatory for ideal gingival scan, because if you are not doing the ideal retraction to retract the tissue from the margins, definitely this scan is not enough to fabricate restoration with ideal marginal seal. Another important message is that soft tissue biotype is a key factor for good gingival retraction, because When you have a thick or thin biotype, deep or shallow sulcus, the need for hemostasis is very important to select the ideal gingival retraction method. And finally, customization of your protocol is very important. There is no single technique is efficient for everything. You can customize according to the soft tissue health and the sulcus depth and even the amount and the depth of your reduction. So this is the end of my presentation today. I was honored to be with you today. I was honored also to share knowledge with you, and you can find the references of my presentation here in this slide and many more regarding this topic. And also, all of the cases presented today are my own cases, and you can find these cases on my social media accounts on Instagram and Facebook. Thank you again and see you. Goodbye.
Okay, thank you for sharing all your tips with us, doctor. So let's move on to Q&A sessions.
Okay, let's go.
Okay, so today we've got 4 questions in total.
Okay,
So I'll start with the first question.
sure.
Question number 1. What are the differences between digital and conventional impressions regarding tissue retractions?
Okay, this is a very nice question, Jenny, because there is a huge difference between the conventional physical impression and digital impression regarding tissue retraction. Because in all situations, after we make reduction with burrs, we can cause trauma to the gingiva, leading to bleeding. And this bleeding with conventional impression, the light body can be pushed deeply into the sulcus to capture the details of the sulcus and the subgingival area of the tooth. But if we have a lot of bleeding, we might have defective margin or incomplete capturing of this margin.
Yeah.
And after boring of the impression, we can see that we have incomplete area of the finish line and a lot of air bubbles, which might affect the quality of the final restoration, like margin deficiency and incomplete seating. This is for conventional impression. But for the digital impression, the problem is slightly bigger because with this bleeding and with this collapse of the impression, the light of the scanner cannot penetrate this bleeding and cannot retract the gingiva away from the finish line. So we must keep the gingiva retracted away from the finish line all over the scan, and we have to make ideal hemostasis for a good marginal capturing. So for this situation, for example, there is a lot of bleeding. Can we make a scan for this situation? Definitely by this way, not. We have to make a kind of modification to capture the margins.
Yeah.
So we need tissue management for digital impression for 3 main reasons. The first one is horizontal gingival displacement. We have to retract the gingiva in a lateral way to record the full width of the finish line. Also, we have to make vertical gingival displacement to record the subgingival part of the finish line to design the ideal emergence profile. And finally, we should achieve hemostasis. So those are the 3 main factors that will control the ideal gingival retraction for digital scan. So definitely, there are a lot of differences that we have to control between conventional and physical impressions.
Wow.
Yeah.
Yeah, I really understood everything. Thanks for the kind explanation and all the slides.
Thank you. And the lectures also was full of tips and tricks regarding horizontal, vertical, and how to achieve a good hemostasis with different material, with different techniques.
Oh, okay. Wow, let's go to question number 2.
Sure.
Okay, question number 2. What is the preferred technique for ideal tissue retraction?
Okay. There is also a very important question because my answer is I haven't one single technique that is most preferred. My preferred technique is according to the situation that I need retraction for. So I need retraction, as I told you before, for vertical and horizontal displacement on the gingiva and to stop bleeding. So for this situation, for example, I need this retraction to retract the gingiva away from the soft tissue, away from the finish line, for a good capturing of the finish line. So for me, tissue management have three main methods, and I can customize every method for every single scenario. I can use either chemomechanical method, like retraction cord, or chemical like based, or surgical like laser or electrosurgery. So according to these three factors, I can determine the ideal gingival retraction method: thick, deep, and healthy. If I have thick biotype of gingiva or thin biotype, if I have deep sulcus or shallow sulcus, if I have healthy or unhealthy tissue. So, for example, when I have a deep sulcus, when I have a thick biotype, I can use retraction cord. And also I use retraction cord with hemostatic solution like aluminum chloride to stop bleeding. And if I am not in need for hemostasis, I like to use BTFE cord. BTFE cord can offer us a very nice contrast between the deep discolored margin of the reduction and the white color of the Teflon, so we can determine the margin. And I like to use automatic margin detection of Medit software, especially with Teflon, because it's very clear to determine between the finish line and the Teflon. And if I have a very thin tissue with a lot of inflammation, I like to use retraction based. Retraction based is not good for gingival retraction, but it's good for hemostasis. So whenever I need a good hemostasis, I can use retraction based over retraction cord to control the bleeding and to stop hemostasis. And finally, if I need a good retraction with a good hemostasis, with a thin biotype, I like to use what we call the magic foam. Magic foam is an expanding polyvinyl siloxane impression or material that can be injected under the sulcus, and with Combri cap, which is a cotton roll that is empty from inside, we can press over the magic foam for 5 minutes. This magic foam will expand, and this expansion will cause a slight and gentle pressure of the tissue to make a kind of vertical and horizontal displacement. And also this expansion will cause a kind of hemostasis, so we can control the bleeding, we can make vertical displacement, and also we can make horizontal displacement. So I haven't one single preferred technique. All techniques are preferred for me, and I can customize each technique according to the scenario. But let me say that retraction cord can do most of these things. But the problem is when placing retraction cord with retraction cord breaker with a high pressure, we might have permanent gingival recession. So we have different sizes of cord, and I should select which size should be suitable for every gingival biotype to avoid any gingival recession. Either size 1 for a large sulcus for a thick biotype, or size 000 for a very thin biotype for narrow sulcus.
Oh. So actually, from my side, it's first time seeing magic foam. So the blue
Okay.
part is magic foam, right?
It's a very famous. It's not new at all. It's a
Really?
very famous material, but I think
I don't know.
the
From my
dentist
side, it's
didn't
first.
know enough about magic foam.
So do we need to use gingival retraction cord first and then use magic foam, or just magic foam is okay?
According to the situation, if I have a very thin biotype, I cannot use both. I will use
Okay.
either retraction cord and magic foam. But if I have thick biotype and I need more retraction, and I will discuss this in details in the lecture, I can make ideal retraction with retraction cord as a vertical displacement and magic foam for horizontal displacement to capture the ideal width of the finish line.
Oh, I see. Okay. Okay. Okay, question number 3. How can you retract for implant a bum at finish line?
Okay. Jenny, this question is a very, very important because nowadays we have a very fast revolution regarding implant prosthetics. And because implant prosthetics can be a detrimental trigger for implant failure. So it's very important to do implant prosthetics with a very high accuracy and precision to avoid any complication regarding implant or bone loss. So for me, if I have a good digital library and I have the scan body of the system, I can take a scan for the soft tissue, then take a scan for the scan body, and with ExoCAD, I can select the ideal abutment and fabricate the crown virtually. So in this case, no need to make gingival retraction. But sometimes after fabrication of custom abutment, custom zirconia abutment, with the finish line is slightly subgingival, I need to make retraction. But thanks to the abutment matching tool of Medit, I also can make extraoral scanning and then intraoral scanning, and then I can do matching between the intraoral and the extraoral scanning, and then send it to the lab very clear with a very nice margins. So what is the problem? The problem is when I have a single piece implant. When I have a single piece implant like this, or in case that I cannot remove the abutment for any reason, I don't know the library, I haven't the screw, cannot be removed, screwed with high torque, like this situation, look for this margin, I cannot scan for this margin.
Yeah.
So I have a defective restoration from mesial surface as you see. So this is a problem. In this situation, we need a good retraction. But the problem is we cannot place retraction cord. Why? Because it will cause laceration and will affect the connection or the communication or the soft tissue attachment with the abutment level. And this pressure with the retraction cord will cause complete loss of this attachment. And also, we cannot use electrosurgery because it's completely contraindicated to use electrosurgery around dental implant. So we can use lasers, but also laser can remove the epithelial lining of the attachment and will cause a little attachment loss. So my preferred technique for this case, for example, you can see deep margins, lots of bleeding. I cannot make the ideal scan. So usually I like magic foam and retraction based because both can cause a little gingival displacement with a little gentle pressure on soft tissue, so it causes a little further or gingival height loss. So there's a comparison between a pre-retraction and post-retraction. We can see that we have a little amount of retraction with a very gentle pressure, which was enough to expose the margin to capture the ideal margin. So my preferred technique in this situation, in case that I have a single piece implant, or I cannot remove the abutment from the implant for any reasons, I will use retraction based, which is usually magic foam.
Okay. Well, thank you for sharing your tips and tricks,
Thank
everything.
you.
Yeah. Okay, last question. Question number 4. So is there any specific case that you take conventional impression instead of digital scanning?
Okay, this is also a very important question, and I'm always receiving a lot of questions regarding this topic. I'm a prosthodontist, and I like to do metal ceramic restoration. Most of my practice was metal ceramic restoration because we might have long span restoration, we might have a Broxer patient, so we cannot fabricate ceramic restoration. So we need a metal framework to support the porcelain restoration. So for me, I was believing that I must do impression, conventional impression, because I was believing that conventional impression is the most accurate to have a good cast and then make a wax pattern and then build the porcelain on top of this framework. But nowadays, thanks to the printing technology, I'm not in need for this anymore. I can take a good scan, I can share it with the lab to print the wax pattern with a metal, or we can also mill the wax and then take this wax to be casted. So we cannot, I think it's 3 years now or 4 years, I didn't do any physical impression.
Any?
Another situation, another situation, which is the last question. If we have deep implant, we cannot remove the abutment and we have to make good scan. In the old days, I was doing a kind of hybrid scan. I can scan the abutment, the neighboring teeth, and the deficient part, I can scan it with an impression. So I make hybrid scan to scan the subgingival part with the scan and subgingival part with the impression, because I can push the light body deep onto the sulcus. But also nowadays with magic foam and retraction based, and even with laser, I'm not in need for this anymore. So in my practice, for the last 3 years or 4 years of my practice, I'm not using any physical impression anymore. I have a lot of physical impression in my clinic as a stock before starting to do digital scan, and all of these stock are expired now.
Wow. Wow. Oh, even for the full arch case, like when you're doing recording bites, do you use
Jenny,
putty or not at all?
I have a publication in the GBD in 2022. This publication is discussing a complete full mouth rehabilitation with a complete digital workflow, starting from the scanning, the Facebook transfer, the mounting on a semi-adjustable articulator, and finally adjusting occlusion in a digital way. So even in a large cases with full mouth rehabs or even implant restoration, I'm not using any conventional impression anymore. And maybe we might have a chance to share this technique and share this with you in another webinar, because full mouth rehabs, and even I'm not talking about recording only the scan or the vertical dimension. I'm thinking of how to use Medit splint, Medit design, and all the Medit apps to fabricate a lossy jig to record the vertical dimension, centric relation, and many cases that might need a small digital tips to achieve the ideal success, especially with full mouse cases.
Wow. There will be so many audience waiting for your stories. Wow. Yeah. Okay. That was the last question. Thank you for answering all the questions. Well.
Thank you, Jenny. Thank you very much.
Okay, that's all about it for today. So you'll be able to watch this webinar on our YouTube channel and Medit Academy. Thank you for being here, doctor.
Thank you. Goodbye.
Bye.
Bye bye.